I really haven't seen it.
I mean, don't let the fact that you're worried about the pulmonary edema keep you from giving the Narcan to someone who is not breathing. Just don't be afraid to give it to someone who's really deep. And, you know, it is controversial. The other thing, just a couple of things I've learned in using so much Narcan at Lincoln, is one, for fentanyl, there it's not just the time it lasts like it does with methadone, where you got to keep watching them, but that might take a lot of Narcan to even get them out of it. So don't be afraid if you think they may have something like fentanyl, you know, to keep pushing dose after dose after dose till they respond. To be honest, I remember one case we went up to almost 10 milligrams before they responded, but that was little by little. And once they respond, you got to watch them because Narcan has a short half-life compared to things like methadone and even some others. So you have to watch them very carefully. Now, one thing you can do that you mentioned, again, you got to always watch them, but let's say a trauma code comes in and everybody's busy with it and you're worried and they keep going down. So you can repeat your bolus and then you can hang an IV drip of Narcan. You still got to watch them, but this gives you a little time.
Yeah.
You know, and I've done that and it seems to work. Again, you got to make sure the IV's working. But that's something you can make a little cushion with.
Yeah, indeed. So the Narcan drip, I don't know if you guys have a cutoff of how much you've pushed before you decide to just convert to the drip. But the thinking, I should put the numbers up here because this is useful. Basically, a couple of the guidelines I found for drips say 0.6 times the initial dose required to get a response from the patient is what you want them to get per hour. So if it took 10 milligrams, or you said 14 milligrams, 10 milligrams, okay, 10 milligrams to actually get a response from that patient, then that person will be getting 6 milligrams over the next hour.
Just really quickly, has anyone, I haven't done this, just heard about it, but nebulized Narcan, did you come across anything like that, or anybody ever use it?
I do it a fair amount of time. It's a small dose to get, most of it goes out to the room, just enough to keep them breathing. But it's a pretty mellow way to do it. It goes in nice and slow. You don't get the personality defects when they wake up from a whole watch dose. Works pretty nicely.
Narcan is a wonderful drug when it comes to absorption. And you can give it nebulized, you can give it under the tongue, you can give it sub-Q, you can give it IM if you don't have access. And don't be afraid to give it if you need it. Obviously, if you don't need it, don't give it. And if you have someone who's addicted and you see their track marks and everything, give small amounts if they're still breathing, as you said, because you will put them in withdrawal, and that is scary. They'll start to vomit, they may aspirate, they'll be shaking, they'll come out and pull out their IV.
Yeah.
It's something to see. That really scares you. But it's a great drug to save lives. It really is.
And with like the prevalence of all these long-acting opiates last like 12 hours and longer, you don't want to wake these patients up. They become really irritable and they walk out.
Right.
Instead, your Narcan wears off and you die.
Right.
So
Yeah.
that's why the toxin advocates for the 0.04 milligrams, doubling until you titrate to an adequate respiratory rate.
Right, yeah. So drawing up that 10 mils, pushing a little bit, getting a response. You should get a response within a couple minutes of pushing, going low. But of course, if they're apneic, if they're close to respiratory arrest, if they're in respiratory arrest, you don't have to just do the small pushes.
And if they're sort of breathing slow, but they're not respiratory arrest, make sure that you say loudly next to them that you're going to give them Narcan.
Yeah, that alone reverses. Anecdotal story. I'm in Philadelphia for an interview. I walk into the basement of a little mall, sitting there doing my thing. Right next to me, I hear the sounds that we're all familiar with. Agonal breathing next to me. Look underneath, sure enough, guy face planted. The door's locked. Hop over the stall there. He is head in toilet, needle next to toilet, breathing at maybe 5 a minute. That guy walked out of that bathroom with the mention of Narcan. Okay, so I actually found him like an hour later, like nodding off, you know, like on his, I woke him up again. So, yeah, I'm killing time. So, yeah, I'm running slow. Body packing is something to be aware of with both of these issues apply to cocaine and heroin. Body packing, you see someone coming from JFK or LaGuardia, think about body packing. They're well, Miralax. They're not well, they might need a laparotomy because the only way to fix 2 kilos in the belly is to take that out. Some adulterants, something we've seen here at Downstate has been levamisole as an adulterant. Now this actually, 78% of people, in one study, 78% of people who tested positive for cocaine also tested positive for this in Colorado. So this is, and in Europe as well, this is one of the most widely used adulterants, probably very close to the source. It causes agranulocytosis, leukoencephalopathy. It can also cause cutaneous vasculitis and tissue necrosis. This other one, clenbuterol, that was a popular adulterant in the early 2000s, hyperglycemia, hypercholesterol. K2. So, yeah. Totally. All right. So, K2, various stuff, various problems, available in This, you want them to admit that they've done this. Important. Marijuana, yes, it causes syncope, whatnot, some anxiety. Pediatric ingestion is what you really what you worry about. It actually has been shown in some case studies to cause respiratory depression requiring intubation. So that's something to think about. All done, guys.
Very good. Very good.